This
It's it's Tuesday, October 8th, 2024. Welcome to the AnCan virtual support meeting for high risk, recurrent and advanced prostate cancer. Thank you all for joining. I'm moderator Ben Nathanson, and I'm joined by moderators John Antonucci and Rick Davis, the founder of AnCan. Len, as you heard, can't be with us tonight. You'll hear medical issues discussed, but we're just a bunch of guys. Nothing you hear is to be taken as medical advice. Funding for this meeting comes in part from the sponsoring companies whom we thank. We thank Bayer, Novartis, Johnson and Johnson, Myriad Genetics, Telix, and Blue Earth Diagnostics. As these sponsors are well aware, we continue to call them as we see them. So let's begin. We have many new participants tonight, and conversations with newcomers lead off our meetings. So, Jerry, you're our first newcomer.
Hi,
Welcome.
thank you. Thanks for having me.
What's your last name?
Frazee,
How do you spell that?
Frazee.
Okay. I'll ask a few questions and then the floor will be yours. Where do you live, Jerry?
I live in Brielle, New Jersey.
Oh, I live in Teaneck, New Jersey.
Okay, not too far away.
How old were you when you were diagnosed?
64.
And what year was that?
This year,
Hmm.
January.
What led you to think you had prostate cancer?
My PSA rose a little bit. It wasn't really high, but it had gone up. It almost doubled from the previous year. So my urologist suggested we get a biopsy, and that came back Gleason 8.
You'd been getting PSAs annually?
I had been, yes.
You'd been seeing a urologist?
Yeah. I had a enlarged prostate for years, but nothing, no thought of cancer.
So what was the PSA? I'm sorry, did you say when you did the
My
biopsy?
PSA was 3.9.
Ah, okay. Um, did you get was this an MRI guided biopsy?
It was not. No, I did not have an MRI before the biopsy or during.
I didn't ask. Where did you go?
Local urologist.
Hmm. You recall how many cores came back positive? That kind of detail.
Yeah, there was only one. They did 12 cores. Only one came back positive. Evidently, the area of cancer was very tiny.
But it was a Gleason 8,
Yeah,
you
it
said.
was later, unfortunately, upgraded to a 9 once the pathology was done.
So what treatment did you first decide to take?
I had a radical prostatectomy.
What made you pick that?
Well, at the time, we thought it was contained, and I just reviewed everything and just, that seemed like the best thing, just to get rid of it.
Right.
But yeah, at the time, it seemed like the best move.
So it was pathology of the removed prostate that led them to conclude it was actually a 9. It's a
Yeah, it
9.
was Gleason 9 with cribiform. I think
Oh,
that's
that.
how you
Uh-huh.
pronounce it.
Uh-huh.
And there was also, give me 1 second, extra prostatic extension
Mm-hmm.
and lymphatic and or vascular invasion present.
Mm-hmm.
Uh, Margins were negative. No involvement with the lymph nodes, and the classification was PT3A PNO.
Mm-hmm. Mm-hmm.
And
Mm-hmm.
Then I had my PSA tested, and unfortunately, it still picked up. It was a 0.16, and
How
then
soon? How
that
soon
was
after this?
in May. So the surgery was in March, and then in May I had the first PSA test, and then I had another PSA in June. It was rising 0.27, and then in July it was 0.34. So then my doctor sent me. Now, by this time, I was being seen at Sloan Kettering. Um, they did a PSMA scan that came back showing nothing, and I also had an MRI showing nothing. And then they started me on Orgovyx, and that's kind of where I'm at now. I've been on that for 2 months. I'm going to be doing salvage radiation. Probably in a couple of months, I'm meeting with my radiologist at the end of the month. So that's kind of where I'm at. Um, yeah, that's where I'm at right now. Yeah, kind of letting
You-
Orgovyx do its thing, and then see what the plan is for the radiologist.
You're seeing them at Basking Ridge?
No, in Middletown, I'm seeing Doctor. My medical oncologist is Doctor Abida, and my radiation oncologist is Doctor Hasseltine.
Um, yeah, Wasim Abida is the top guy.
Yeah, I like them a
So
lot.
good.
So, for the uneducated, is Middletown the same as Monmouth Hills?
No,
No.
I'm not even
Okay.
familiar with Monmouth Hills. Um, it's near Lincroft or Middletown. Well, it's
Okay.
actually in Middletown.
Because I was only aware they had two sites in Jersey, Baskin Robbins, Baskin Ridge, and You get all the flavors at
Yeah.
Baskin Ridge. Um, Baskin Ridge and Monmouth Hills. Monmouth Hills is on the east side, sort of south and east is Monmouth Hills. It's about an hour north of Princeton. Um, but I didn't realize they had a third facility there. And
Yeah,
I'm real
right off of exit, I want to say 114 on the Parkway, New Jersey
okay.
Parkway. Pretty
Okay.
much central Jersey.
Yeah, it's interesting. Also, it's interesting that Abita's there
Yeah.
because
Well, yeah, he's filling in for somebody, and he said I can keep him if I want to when he formally goes back to New York.
okay,
So,
you keep him.
okay,
Okay.
good. That was one of the things I wanted to find out is
Yes.
what you guys thought of him. Okay, good.
You definitely a keeper, Jerry.
Great. Excellent. That makes me feel good. Any um, I, opinions on Dr. Hasseltine?
Don't know him. Sorry.
Okay. How about a Dr. Gross?
No, we're not great on the satellites. MSKCC, the docs we know best are the ones who are on Second Avenue.
Okay, right.
To be honest, so uh, yeah, it's I mean, I know a couple of them at Monmouth Hills because I had a guy. We lost him with serious bladder cancer who was treated there. So I know quite a few of the guys there, the names, but I'm not so good now. That doesn't mean to say that we don't have other guys in the group who have gotten treatment at Baskin Ridge or at Monmouth Hills or in Middleton who might know some of those peeps. So we can anybody here getting treated in Jersey or Westchester at MSKCC satellites? Guess not. sorry, can't help you with Hasseltine, but
Okay.
we're
Jeff, Jeff, your hand was up.
Yes. Yeah, I got treated at Sloan Kettering in Westchester.
okay. Okay. But you don't know Hasseltine. He doesn't hang out in Westchester, only in the middle of New Jersey, right?
No, I
Yeah.
have Dr. Keegan.
Okay. Yeah.
Yeah, I think see, originally when I first saw Dr. Abita, I saw Dr. Gross, a radiologist, and he was leaving. And I haven't, and so my new doctor is going to be Hasseltine. I haven't even spoken with him yet, but I believe he came from New York. I guess I just happened to get like in the middle of when people were changing when I first went there. So, uh, yeah, I haven't even talked to Dr. Hasseltine. His credentials look great, but uh, yeah, I don't have anything else to go on other than that. And he was recommended by Dr. Gross before he left. My last time I spoke with him, he highly recommended him. So, um, the one question I did have is Dr. Abita only has me on Orgovyx for 6 months.
Right.
And he said that's because there's no lymph node involvement. Uh,
Right.
just from everything I've researched and I've been watching you guys for months, that just seems like a really short time based on my diagnosis with Gleason 9 and extension and
Yeah.
things like that. I just kind of wanted to get anybody's thoughts on that, or I don't mean to question my doctor, but it's just,
No. You should question your doctor. There's
thank
nothing
you.
wrong with that. So it's clear from the guidelines that with T3A, you're not eligible for a second line anti-androgen because I personally have been looking at that quite a bit and went back, looked at the NCCN guidelines. And if you're T3B or T3C, you would get abiraterone. T3A, you don't.
Okay.
Um, that said, I would tend to agree with you that 6 months on Orgovyx is a little short, but that's what some of these guys want to do on salvage.
Okay.
Um, if you were T3A and had chosen to do um, radiation, you'd almost certainly be on at least 18 months.
Okay.
Um, and whilst we can't give medical advice, it seems strange to me. And I don't know, I'd like to ask the other mods what they think or anybody else in the group um, that you wouldn't be on 18 months if they had to come in and radiate later.
Hmm.
Um, and yet we've seen this before. And it's because the guidelines, I believe, just say 6 months. But if you want to be conservative and stay on for longer, you can discuss with the beta. Some of this is about doing no harm, so they don't want to do more. But
Right.
I do find it strange that somebody who's T3A, they'd only put you on 6 months, whereas if you had a prostate, they would have put you on 18 months.
Okay. Yeah, he said that if the lymph nodes became involved, then it would be longer. But because of the MRI and the PSMA didn't show up anything.
Yeah.
I assume that hasn't changed. I haven't talked to anybody since the PSMA scan and the MRI. Or no, I'm sorry, I haven't talked to a beta since they started me in the Orgovyx. So I don't know. I assume since everything came back clear that that is what we're going to be doing 6 months. Um, and they've kind of left it. I'm doing physical therapy for incontinence right now. So they're trying to give me as much time as possible to get that under control before I do the radiation,
Right.
Right.
because I understand become permanent or wherever I'm at. So another thing I was going to ask them if it would be possible if I'm not continent in the next month or two, if we can extend the Orgovyx and extend the time to the salvage radiation, if that is something that's even possible without putting me more at risk. Um,
Well, there was a study some time back, and again, one of the guys may remember, that seemed to think that if you started the salvage radiation within 9 months, that wasn't an issue, which would take you through to the end of the year. Because there was a time when they wanted to do that, get that salvage radiation going within like 120 days or so afterwards.
okay.
Um, but there's now evidence that it doesn't seem to make a lot of difference. So you have time, I think, and it's definitely a good thing to try and get the your incontinence managed. Um, but as to the period on hormone therapy, and what are some other people? Any input from anybody else here in the group?
Yeah, so I'm one of those people who had 6 months of Orgovyx with the radiation, and so far, I think for the last 18 months, I've been undetectable. So that did work for me. I know that's not everybody's situation, but it did
Right,
work for me. And
right.
when I questioned Dr. Gainesman about it, he kind of he was very firm. This is what I'm going to do. This is what's best. I've got research to back it up. That's what we're doing, Alan.
Yeah, there is research to back it up. I remember having the discussion with you at the time. So,
Yeah. So
Well,
far so good, but so
good to know.
Robert, your hand is up.
Yeah, I did 6 months as well, but I was on a clinical trial, so it was Orgovyx along with apalutamide and then some radiation at the same time. But so because of the trial, it was just 6 months.
Okay.
But you'd actually also had salvage radiation.
I had salvage radiation prior
So,
to that with no
so,
ADT.
so, so it's not exactly the same thing. You're
No,
you're a special case.
thanks.
Uh, Jeff,
let
your
me
hand
add
is also.
something I wanted to add to because it's gone through my head, and that is that I told Dr. Gainesman that I had a recommendation from this group, and that wasn't the best thing. I talked to Len about it, and I said, "Don't do that. You look up the research and tell him you've read this research." So, just a word of advice, not to just say, "Okay,
Okay. Thank you.
AnCan told me that."
I won't throw you guys under the bus.
Yeah, that's right. Big mistake. Well, not a big mistake, but I wouldn't do it again.
Is there any questions that I should be asking my radiologist? Um, Obviously, it's the first time I've been through this, and I've done my own research, but just some guys have been through this, so I'm just curious if there's anything that was unexpected or you weren't expecting, or yeah. Actually, I don't know what to ask.
So I have a question to you, Jerry. Have they said anything about you getting fiducial markers, even though you've had a prostatectomy and you're going to have any discussion of having fiducial markers put into your prostate before the radiation or what's left of your prostate?
No, there was no mention. I know they mentioned doing tattoos, but I assume that's on the outside.
Right.
Um, that's it. I only had in kind of an overview discussion about the salvage radiation while we were still waiting for the PSA results. Um, or actually, we had gotten the PSA results and they wanted to wait and see which direction the next one went. So in that time, we kind of briefly talked about it, but there was no talk about that. I don't even know. I think I'm only going to have 20 sessions of radiation based on the fact that there was no lymph node involvement, if I remember right. But again, that was just an initial conversation, so I really don't know what they have planned, but I don't remember anything about what you're speaking of.
I would ask them because I mean,
Or-
I've read papers that say it's beneficial to allow them to pinpoint the radiation, even though you've had your prostate removed. But I would ask the question: Is there any benefit to me to having any fiducial markers put into the prostate before the radiation starts.
Okay, great. I will ask them.
Well, I think the question's a little bit different. If I could just rephrase it, Dr. Jeff, which is the question you need to be asking is how are you going to guide this radiation?
Hmm.
That's the question you want to ask them, because there are different ways and methods of guiding. One is fiducial markers, for sure, but there are other ways that they do it today. I mean,
Okay.
they can do it with transponders, and they can do it with they do a CT scan before you start each time, and there are different ways of doing it. What I think you want to be sure of is to make sure that it is guided, which I'm sure it will be, and
Hmm.
then understand how it's being guided, and then come back to us and talk to us about that, and we can help you.
Okay. All right, great. Now, if even though there's nothing being picked up with the MRI or the PSMA scan, is there? I'm not sure what do the what do they base these markers on? Just anatomic areas? Because if there's no cancer to pick up, what are these markers going to?
Well, I mean, what they're doing is they're mapping an area on your across your pelvis that they want to radiate,
Okay.
and they want to be sure that they hit the areas that they want to give radiation, and not areas. So they want to avoid giving areas to your giving radiation to your rectum if they can help it.
Right. Okay.
And so the markers that are put in are just basically so they can triangulate, because that's how certain machines operate. They operate on a triangulation system, but there are other ways that machines operate, and I'm not the expert. Dr. Mark Perlow is the expert, but he's not in the room today. Sometimes he comes in, sometimes he doesn't, and I don't know. And there are some other guys in here, I'm sure, who are knowledgeable on radiation. But the point is, it has to be guided so they don't hit areas that are super sensitive.
Okay. I know that was discussed about because I had asked them about a spacer, and then I found out I wouldn't need a spacer because I don't have a prostate
Right.
anymore. So there was discussion about not hitting things that didn't need to be hit with radiation, and that's what I remember. So, but I will definitely bring that up when I have my meeting with them, to make sure, and then I'll come back here and let you know what I find out.
Yeah, do come back. Like you have a little headroom before you have to make any binding decisions.
This is
Yeah.
So,
John. I've been mucking around in the NCCN guidelines for Jerry, but I do not see a clear statement about 6 months versus 2 years of ADT.
Mm. I'm pretty sure, John, that it came from there was a trial with um, salvage and 6 months, and that's what.
Mhm.
And I can't remember the name of that trial, but that's why they all went to 6 months. They all went to 6 months. They all
Mm.
base it on that trial of,
Okay, yeah,
and I can't remember the name of it. I could find it. I know I've got it bookmarked.
because I
But
know
I just,
this used to say uh, something different
well,
years
if
ago.
you look at the guidelines for um, radiation prior as primary treatment, it's going to say 18 to 36 months as primary treatment. But as salvage treatment, it's different.
so in light of this is not a decision that needs to be made now. This is a decision
Right.
that can be made six
Right.
months from now. So in light of the rush hour crowd in the meeting,
Yeah.
I'm going to
I
move on to
agree.
the.
I
I,
agree.
I appreciate the time. Thank you.
Thanks.
Yeah,
let's just check with you, and this is for all the new guys. Have you signed up for our reminders yet, Jerry?
Yes, I have.
Okay. For all the new guys, if you have not signed up for a reminder, please send us your email. You can either put it in the chat window for everybody to see. If you want other people to communicate with you, you can send it to Ben or to me personally through at the bottom. Send a message just to us, and we will make sure we get your name. So that would be true for Bill, Robert. I think we have Tom Hoffman already, and for Frank Chiambra. Um, and then you'll be able to read our newsletters, and you'll get a reminder before every meeting. Oh, and Jim Marshall has his hand up, and I think I know why. Go ahead, Jim.
Yes, and by chance, if you are a veteran, okay, there's a veterans group that you should definitely sign up for. We meet next Tuesday, 8 o'clock in the Schmear room.
And Jim's shortchanging himself, because that if you are a vet, if any of you are vets, then we can almost guarantee that going to that meeting will make a difference in terms of your benefits and or your health care. It's a very, very good group. Includes some VA career employees like Dr. John and Sylvester Mann, who's not with us today. And these guys know the ins and the outs. So we strongly recommend it. And nobody can quote alphabet soup in the VA like Captain Jim.
Oh, thank you, Rick.
Tony, I see your hand is up.
Yes, maybe I missed it, Jerry, but I was wondering if you had done any genetic or somatic testing at this point.
Yes, I did. I do not have BRCA, and I had something unrelated, but it's MUTYH. I think it's more related to colon cancer.
Yeah.
But that was all that came back. So that's the only testing I've had so far. Is there anything
Okay.
else that I should look into?
Not right now.
Okay.
Good question, Tony. So, Robert, you are our next new guy. I won't let you go to next week because I've studied up on your case. I'm all prepared. Um, Welcome. Appreciate your coming. Um, so, Robert has sent to us a detailed list of his history, but we're going to go through at least an abbreviated version so that everyone else can make informed comments about his case. And if I, in my haste, leave anything out important, I hope someone will tell me. So, Robert, how old were you when you were diagnosed?
61.
And where do you live?
I live about 80 miles outside of Chicago in a little town of Alden.
And what year were you diagnosed?
I was diagnosed in 2020, November of 2020.
What what led you to think you had prostate cancer?
My first PSA test ever came back at 10.9, and then I was sent to see a urologist, and digital exam confirmed that he felt the mass, and I was sent for a biopsy.
What did you ask for the PSA? Is that why you suddenly got one?
No, I think it was just because I was 60, 61. I had never had one before. They just ordered one.
Hmm. So I'm sorry, you just said your PSA was at the time was
10.9.
yeah, yeah. So It was confirmed by a biopsy.
Yes.
Uh, did you get an MRI before the biopsy?
Um, I don't believe so.
So you recall details of the biopsy, like how many cores the Gleason scored?
There were 10 cores, and I guess 6 found something.
Mm-hmm. Mm-hmm. And so what treatment did you decide to take initially?
I had radical prostatectomy.
And why did you choose that?
There was some perennial spread, and thought that if we did that, hopefully that would be pretty much the end of it.
So you did get the prostatectomy. Did your
Yep.
did your Gleason grade go up from the biopsy?
Um, I'm not sure. I
So
think
I
it
think
was
you. Mhm.
I think it was an 8 beforehand, and it might have gone up to a 9. I'm not sure on that.
And they found extra prostatic extension. You were PT3A,
Yes.
but
Yep.
no nodal involvement, no distant metastasis, N0, M0.
Yep. Correct.
But subsequent to this, your PSA rose again. How much later was that?
Over the next 6 months, well, even after the prostatectomy, it never went below 0.37. And
No. Hmm.
then, and I had the surgery in March of 2021, and then in September of 2021, I started salvage radiation without ADT. And at that point, it was 0.69, and at the end of it, it was 1.29. So it went up.
So why no ADT? Did you decline it, or they didn't offer it?
They didn't offer it with the radiation. No.
And so afterward, you switched to. So you had been getting treatment locally from local doctors,
Correct.
and after the salvage radiation, you switched. Good move to Northwestern.
Correct. Correct.
What made you do that?
I thought I needed to see an oncologist instead of just a urologist, and so I made the choice to do my homework and see where the best ones were, and Northwestern seemed to have the best ones. So,
Yeah, yeah,
at
good,
least in this area.
good choice. So who are your doctors now?
Uh, Dr. Vanderweel is my oncologist, and then Dr. Sachdev is my radiation oncologist. And then Dr. Bugno did radiation this summer.
Right, right. So that's yet another kind of a round of radiation. Your PSA continued to rise after the salvage, and the PSMA PET had found a metastatic lymph node in your lung hilum,
Correct.
and you signed up for a trial, which seemed to be
Correct.
almost tailor-made for that kind of condition.
Correct.
You'd gotten ADT, you'd gotten Orgovyx and Erlita and spot radiation to the tumor.
Correct.
And that seemed to work. And they cruelly told you that all known cancer had disappeared. This was in August 2023.
Well, I took all known as very caveated. So,
Yeah, wisely. Um, and indeed, by December of 2023, your PSA had started to rise again. And this past
yeah,
August,
shortly after
it
stopping
rose.
the trial. So
Hmm.
it started to
Yeah,
go
they
up shortly.
they were ready to declare success, but the cancer had other ideas. So by this August, it was past 10, and you went back on ADT, this time under your Northwestern guys, and you've been taking Orgovyx and Xtandi,
Correct.
enzalutamide.
Correct.
So the big thing that you had complained about, it's kind of the outlier. So you've had the usual side effects from ADT, but the worst has been the joint pain.
Correct.
You want to talk about that?
Well, it happened when I was on the stuff the last time too, but I knew it was a trial and that it was gonna, there was an end date, so I just kind of, powered through it. So this time, knowing I was going back on it, wasn't real comforting. And now that I'm 2 months into it, uh, it's making it difficult to climb the 21 stairs to my apartment and to do the normal types of work that I do with my hands. So it's pretty discouraging right now.
So this isn't all of your joints, some of your joints?
Mostly my knees, my hips, my hands, and my wrists.
Have you told your medical team about this?
I see my oncologist in a couple of weeks, and we will be discussing this. The I think the last visit was 2 months ago when I was just starting. So I think I see them like every 3 months. So, but it had all subsided when I was off of everything. So I know it's just not degenerative changes as I'm getting older. Because
Right.
when I was off drugs, it took a few months, but things all got back to normal again.
That's right.
So
That's right.
yeah.
And now, of course, you're on a different second drug anyway. You're on Enza instead of apalutamide, and you're still getting
Yeah,
the
so I was
same.
hoping maybe that would be
Right.
less, but it's not.
And yeah, you're wondering whether you want to keep doing it.
Yeah, yeah, or if there's other things out there besides these, the two that I'm on, or if this is just how it is, if these are the things that I need to stay on, are other people on them? Have the side effects subsided over time? Are these side effects cumulative to where they don't go away after you're on the stuff for so long? Those types of questions are what I have.
Those are good questions. Rick, are there factual questions that I missed, or should throw it open?
No, I think what we want to do is hear if anybody else has had a lot of joint pain early on in the game and then it subsided, and what other things we might consider to alleviate the joint pain, and just like to hear from some other guys, and try and give Robert some comfort in terms of staying the course, because that's really what we would recommend, and hopefully get you into a spot where you can get onto intermittent, just like a lot of these guys are. I was just going to ask David Muslin, and he just put something in his mouth. So now I don't know whether he can speak or not. Swallow quick. I'll keep talking. Swallow. Go ahead, Mr. Muslin. You're in the Chicago area. What do you know about joint pain? Anything? Oh, we can't hear you, but you're. Well, that's no good. We can't hear you, but it says that you may have to come in and out, or you may have the wrong thing. Let's go to Jeff Marchi, and we'll come back to you. Then you can have time to swallow. Go ahead, Jeff Marchi.
I was just wondering if he'd heard about darolutamide and its much lesser side effects.
No, no.
Oh. Were you in the Mayo group?
No, it was the
No, it's just chat group. I meant chat group. I was just wondering. Because darolutamide is
oh
much
yeah, yeah,
easier. Oh, so Jeff Marr is the one that sent you here?
correct.
Yeah, that's me. Um,
Oh, nice to meet you.
but I'm surprised I didn't mention darolutamide. It's the enzalutamide and apalutamide are quite a lot more difficult on the body than darolutamide. And you should ask your doctor about maybe getting that since you're having side effects from Daro, from Enzo. It's not unusual. People have a lot of issues with enzalutamide, fatigue, um, the number of issues. So you might want to ask about that specifically. Darolutamide's a lot more expensive, but if you're on Medicare, it's gonna and then there's a lot of help from Bayer, and it ends up being very little, if nothing.
Okay.
Or even abiraterone, then he gets to take prednisone.
Oh, wonderful.
Prednisone makes everything feel better.
That's true, yeah.
So, Jeff, your hand is up.
Yeah. So are you having joint pain or are you having muscle pain and joint pain?
Both, but the joint pain is worse than the muscle pain.
And has your doctor suggested any kind of physical therapy for you to kind of help with the pain?
No, not yet.
You might ask them, to give you a referral to a physical therapist who could help you with the discomfort you're having. Does anything make it feel better, like hot compresses or heating pads, or you're just in pain regardless?
It's in so many different areas. It would be difficult to heat everything that's aching at one time.
And have you tried any anti-inflammatory medications?
Just like Tylenol or something like that, you mean?
Well, maybe an NSAID. Have you tried an NSAID like
No,
Motrin or florbiprofen or something along
no,
those lines?
no, no.
So you should ask them, you know, could they prescribe a anti-inflammatory, not Tylenol, but an NSAID to help you with the pain?
Okay.
Steve Rue,
Thank
your
you.
hand is up.
Uh, yeah, I just wanted to pipe in that the prednisone and the Orgovyx and the abiraterone, I think that prednisone really helps. The abiraterone was kicking my butt for a while. I was having hip pain and pain in my wrist and hands. Uh, but I've been working out and trying to get to the gym more often. And I do take Aleve. And I think the Aleves are an NSAIDs. And uh, I've noticed just in the last few months, the last 5 or 6 months, since I started a regiment working out and getting down to the gym a little bit and trying to do more activities, walking. Of course, I adopted a rescue dog, so now I'm walking a whole lot, but but it's really made a difference with the physical activity with some of the joint pain that I was having. That's all I wanted to throw in there.
Thank you for that.
Thank you. David, it looks like you have a shot now. It looks like you're between bites.
Oh,
Can't hear you. Although your microphone is not muted. Oh,
no. Check, check your settings and make sure that you pick the right microphone there, Mr. Muslin. And if not, you can call in and leave your thing on, and then we'll come back to you. But his question is in the chat, and the question is, Robert, when was the last time you had a PSMA scan?
Let's see. It was in August of last year. Oh
of
no, March of
23?
this. No, I had another one in March of this year, and all was
Okay.
good.
And everything was good on the one of March. You didn't show anything. So they've been monitoring you pretty regularly to make sure that there's nothing new showing up. I mean,
Correct.
what I would say from just being around this for a long time is it's not unusual for some men to respond um, with sort of rheumatic pain and muscle pain when they first get on. And and I do think that the suggestions that you're getting here are real good. Um, I'd encourage everybody, if you've got side effects and things don't seem right, reach out to your doctor. Don't wait until the next time you see them because you don't need to be a hero. There's a lot that can be done, just like Dr. Jeff suggested in terms of the NSAIDs and starting some physical therapy. You've got to be exercising, and that's not just sort of walking up and down the 21 steps or moving furniture around. Okay. Uh, I that's I think that's Mr. Muslin, and it means you got to silence your. He's on it. I can see him nodding. So caller O2 is David Muslin. Um, so you've really got to do some serious exercise. A to help you with this muscle pain. I know it sounds counterintuitive, but it does work, as Steve Ruhr said, and uh, and B, because the hormone therapy is going to require you to do it to keep yourself in shape. Now, the other thing that I really recommend you do when you see Dr. Van der Wheeler is you ask him to give you a referral to palliative care. And palliative care is symptom management, it's not end of life. And Northwestern has a palliative care group. And they're the ones that are going to be really working with you on a regular basis to manage these symptoms. I mean, Dr. Van der Wheeler will too, but they're going to be there to help you with the physical therapy, to talk to you about the pain meds that you need, and anything else. And the sooner you get a good palliative care provider on your team, the happier you're going to be. So,
I can second that. I've used Northwestern's palliative care, and they're fantastic.
Okay, thanks.
I mean, if you're saying literally, I'd rather die than stay on this stuff, then then don't wait.
yeah,
Um,
Harry, who do you see there? Do you have a name for Robert?
I go to a Glenview location. It's not the city location, and I can't remember the woman's name. It's Stephanie. I could look it up and type it in there, but I go to a Glenview location. I don't know what
Okay,
location he'd be going to.
okay.
Tony, your hands up.
Yeah, I was wondering if fluid accumulation in the joints could be contributing a lot to it, and if you have exercise, it would move the fluid away and help reduce some of the pain and inflammation there. I know a couple people that have had joint replacements and they haven't continued on with their physical therapy. Then they get a lot of pain. There's fluid accumulation, and then other joints start to get the fluid, and it causes a lot more pain.
I have no idea.
So yeah, what Rick says, you should not wait for your next turnaround. You should reach out to them, tell them you have these symptoms. Your
Okay,
doctor doesn't want you to be suffering. and your doctor
Appreciate that.
has no idea that this is going on.
Thank you.
Anybody else for Robert?
Any
Uh,
genetic info? Have you
oh,
done a genetic have you done either
Yeah, I think
germline
there
or
was
somatic
nothing
testing?
showing anything on that. I forget what it was,
Okay.
when it was, but yes, I did have the Tempest genetic
Oh,
testing.
right. Yeah, I see it now. Yeah, yeah, yeah,
Yeah.
yeah. But that mean, by the way, Robert, um, it can change over time. So if you had Tempest back in 21, you might want to talk to Vanderwheeler about, should you get tested again at some point?
Okay. Is there a different test that I should have? Different genetic test, or have they
Temp,
improved over the last couple of years? They're all pretty much the
No,
same.
I mean, I would say if it depends what he uses, but Tempest is good. Myriad has one. FMI has one. I would
Okay.
say Tempest also screens for RNA, as does Boston Gene. So, but Tempest is great.
Okay.
You could stick with that. David Muslin, can we hear you now? I guess not.
can't see him either.
Oh, he's just come in again. He's just come in again. Oh, can we hear you this time, Mr. Muslin?
Testing 1 2 testing. Can you hear me?
Yes, we can hear you.
Switch to my
Welcome.
computer. Sorry about that, guys.
Okay. Anything else you'd like to say to Robert before we move on?
No, sir. Hang in there, Robert. The last question I do have, though, has the PSA come down from 10?
Oh yeah, the first month that I was on the stuff, it went down from 10.58 to 0.09.
Perfect. Great. Good luck. Good luck, Robert. However we can
Thank
help
you.
you.
All right, thanks guys. I appreciate all your help.
So our next new guy is Bill. Hi, Bill. Welcome. So
Hi.
what is you what is your last name, Bill?
Untight. It's spelled Untied.
And where do you live?
I live in Bloomington, Minnesota, suburb of Minneapolis.
And how old are you?
I'm 68.
How old were you when you were diagnosed?
68.
Uh-huh. So,
June June of 24.
yeah. Um, what led you to think you had prostate cancer?
Rising PSA, spring of 2023. So I saw a urologist, sent me for an MRI, came back indicating a PIRADS 5 lesion. So I had a fusion biopsy, uh, 14 cores, all benign, including 5 cores on the lesion. So they said, congrats, it's benign. We'll check your PSA again in 6 months. Went up to, so March of 2024, PSA was 7.9. So they did a transrectal ultrasound biopsy. 13 cores, 6 were positive. Highest is Gleason 8, 4 plus 4.
Where was this done?
Uh, at local urology clinic here, Minnesota Urology.
So tell your PSA when you had the negative fusion biopsy was what did you say?
4.5.
Okay, okay.
And then it went up 6 months later. Well, 6 months after that initial biopsy went up to 7.9.
So what treatment did you choose?
Well, with the little bit of education I had, um, and being in kind of a panic mode, I decided to go to Rochester Mayo to see if I could get. I thought I was really curious about proton beam therapy.
Mm-hmm. Mm-hmm.
So I think I made a little mistake in my urgency of, uh, who can I, when's the soonest I can get in, thinking
Mm-hmm.
this is really, really urgent. They scheduled me. First one was 6 weeks out. Then they said you could be on a waiting list. So I did that. They moved me up, and I ended up with a fairly new radiation oncologist, board certified in 2021. Um, it wasn't a really great consult. He was against proton therapy, and I was too ignorant to ask a lot of the questions I think I should have asked. Um, but he couldn't really give me, I didn't feel, a really good reason. He wanted to do IMRT, which I think is probably most common these days for my situation. Um, I asked about, do you use space? Or he said, no, don't need it. Will I have urinary side effects? No, you won't. Um, and regarding proton therapy, I really got the feeling that it was an insurance issue. He said, even if we offered it to you, your Medicare Advantage would never approve it. Asked about my insurance company, said, oh, they're the worst. They won't pay for anything. So anyway, then the next step was a Polarify PSMA PET scan, which showed one aortocaval posterior node with a tiny possibility, a tiny bit of uptake of Polarify. And so after all of the Mayo investigation, I decided to get a second opinion. So I decided to go to Dr. Rossi at California Protons. And I had a great consult with him. I was really impressed with him. And I knew a little bit about his background and how many patients he'd treated over the years. And so he didn't think that lymph node was metastatic, but he said, I'll treat it anyway, along with all your pelvic nodes. He said, really, it's a pretty straightforward case, tumor on the left mid gland. And, but then, of course, my insurance denied coverage. So I'm going to appeal it. Their statement about the rejection has to do with the provider didn't submit enough or didn't submit evidence of experience in data collection and analysis and peer-reviewed articles in the publications. So I would think that would be pretty easy to refute. I know Dr. Rossi has published. I think I've found 23 articles. California Protons will do the appeal, but in order to do that, they want me to schedule treatment first, pay up front for the treatment. So it's a roll the dice thing. So I'm in this situation of, should I just have IMRT?
Also, I've got, open enrollment starts next week. I've considered, what if I switch to original Medicare? Well, I probably won't be able to get, but I don't know this, a supplemental policy offered. And if I do, what will the premium be? Dr. Rossi said, I talked to him about, well, what's the urgency of treatment? He said, well, as long as you can get going on ADT, which I did. I've been on Orgovyx for a week now. He can't prescribe in Minnesota, so I initially got my primary care guy he agreed to prescribe it. But Dr. Rossi said, yeah, you could wait. You've got time to wait till after the first of the year, which is when original Medicare would take effect. So I'm kind of looking to the group. Number one, Rick, I know you have a list of GU oncologists that are top notch. Do you have anyone in the Twin Cities here or at Rochester that you would recommend? I did make an appointment with one of the top guys around here, but I have to wait 3.5 months. Okay.
Who was that?
Dr. Mark Wilkowski.
Yeah, but when you say a top guy, is that a radiation oncologist or a GU medical oncologist?
GU medical.
Okay,
So
and where is he?
he's with the Frauenschuh Cancer Clinic at Methodist Hospital here in the Twin
Yeah.
Cities.
Look, if you're going to if you're looking for a GU medical oncologist in Twin Cities, there's no one better than Dr. Antanarakis at Masonic.
Okay, that's University of Minnesota, right?
Yeah. Antonarakis, Anton Arakis. I'll put something in the chat window in a minute.
Thank
now,
you.
There's a lot going on here. We in this group are not proton proselytizers.
Right.
We just don't see. It's not bad, but it's not good. It's no better than anywhere else. And there are 2 papers in 24, one from March and one from July. And I'm going to write them up for the next reminder. I meant to do it for this one and it slipped. But one of them we've already written up, the March one, which just don't show any hard evidence that it's worth spending the bucks on the proton. Now, what you really should be looking at with 4+4 and possibly T3 is the standard of care, the gold standard of care, which today is probably a couple of treatments of SBRT to the gland and then a follow-up with 20 to 25 sessions across the pelvic girdle, plus somewhere between 18 and 36 months. And that's definitely approvable. And I'll come back to the Advantage traditional Medicare momentarily.
Sure.
But that is very doable. It was considered to be standard of care with brachy plus the IMRT, but the science has moved on to a point where you probably don't have to do brachy. You can get that same impact with 2 treatments of SBRT, although some people will give you more than 2 treatments because they can and they can bill for it. But at UCSF with Mac Roach, he only gives 2. He doesn't think you need more than 2, and we've seen that elsewhere. So if I was in your shoes, well, I sort of was in your shoes because I was a T3A. You're more likely a T3B, but I was a T3A, and that's what I did, and it did give me a durable remission. Doesn't mean you'll get it, but I think that that's a very sensible treatment path in your case. Now, can you get that without schlepping to San Diego? Yes. I'm sure you can get it at Masonic. Um, I don't have the name of a good RO at Masonic for you. I can look. I'm sure we've had people at Masonic, so I'd have to go back and I'd have to look and see who who was preferred.
Okay.
Do you need a GU Medonc at this point in time? Mm, debatable. If you have a really good academic radiation oncologist, I think that might suffice, um, largely because we're not too sure about that node.
Right.
Um, but if you wanted to bring one on board and they felt you could bring one on board, then Dr. Antanarakis is the man to see. This is all in my view. Let me lastly briefly touch um, on the Advantage versus the traditional Medicare. You're 68, so you've been on an Advantage plan for 2 or 3 years, right?
2 years. Yep. So I
2 years.
know about, yeah, subject to underwriting now if I
Yeah,
switch.
it's going to be really tough for you to switch. Okay. Now, does that mean I don't know whether you can switch Advantage plans?
Right.
And what I would say is look for an Advantage plan in your area that includes the University of Minnesota.
Yeah. My current plan includes U of M.
So I
So
personally, I wouldn't knock yourself out. I mean, I'm actually looking at this personally for myself right now because I just found out that my plan is being cancelled. And so I've got to switch plans. And when your plan gets cancelled, and this is something helpful for everybody here, if you're an Advantage plan that gets cancelled, you can switch to traditional Medicare without underwriting.
right.
So for
Yep.
me, it actually happens to be an opportunity. And what I'm looking at is my maximum out of pocket, out of network versus what it's going to cost me to go to traditional Medicare on a G plan plus a D plan. So that's really the math, but I won't go more into it. But if it were me, I wouldn't knock yourself out. I would. University of Minnesota is very good. It's a good academic center. It's got some great docs, and what you don't want proton anyway. What you want is SBRT to the gland, and then the IMRT. I mean, you could do it with you could do it with proton beam. I don't know that Rossi does SBRT with proton because you can
No,
get
they,
SBRT with proton, but I don't think he does it yet.
no,
So
from what I know, he did a short, did a group of like 42 patients. I don't know, a year ago, maybe. I don't know the
yeah,
date, but he said um, it was there were too many side effects.
too many issues. So
Yeah.
I would be moving your care. You're on the Orgovyx, so stick with that, and you'll be ready in about 6 weeks. Get yourself over to a radiation oncologist at Masonic, and talk about. Tell them you want. Tell them that what you've heard is standard of care for where you are is 2 SBRTs and a bunch of treatment to your pelvic girdle, and then stick out the 18 months to 2 years or 24 or even 30 months, and hopefully you'll get the same result that I got.
Wonderful. Um, so one thought I had about proton is I think I have read, that if you have had um, IMRT or photon to your pelvic region or to any region, and then say years later it needs radiation again in that area, that they can't do it then? Is that not an issue now, or?
Not really. I mean, it's a sales issue for it's a sales issue for a lot of urologists who try to run you into surgery. But in fact, today we have so many different types of treatment that we can usually come up with something that can um, that is either radiation or radiation like that can treat you, so it doesn't prevent second rounds of treatment.
Okay, thank you. I've read a lot about the Meridian machines and Electa Unity and these small
Yeah,
margins they have.
yeah, yeah.
Do you guys have any kind of a list of facilities that have these, or is it really not, these 2 millimeter margins versus whatever it would be 3 millimeters? I don't know.
So our expert on that again is Dr. Mark Perlow, who moderates the low
Yeah.
intermediate group,
Yeah, I've
and
seen him
he
post on this in a
yeah,
couple
and
groups.
and
Yeah.
and his you can write to him. It's mperlow, Perloe, mperlow at ancan.org.
Okay.
He definitely has lists.
Okay.
Um, whether I don't know what's available in Minneapolis, he might do. Um, whether it can be combined with pelvic girdle radiation and some sort of treatment to the gland, I'm just not sure. I don't know enough about it. You'd have to ask him. But I would
Yeah.
say that is standard of. I mean, I would say that regular IMRT plus either SBRT or brachy to the gland plus hormone therapy is standard of care, and I just don't know how Meridian or Electro plays into that. I don't know enough, but you could ask Mark.
Okay. Thank you.
Michael
Um,
McCabe, you've been waiting patiently.
Um, I just wanted to say one thing about the space ore. I believe you mentioned.
yep.
I am a believer in that. Where I went at that time to get the what is it called, IMRT or whatever it's called, was done exactly the way Rick described it. To a couple of times to the prostate and then the pelvic girdle. But it was like not even a question about the space ore. The guy was really good where at that time where I was about that. He was great. I did move on now to UW-Madison Carbone Center. But anyway, at that time, we talked to guys that were in the room and were going and waiting for our turn. And there were ones that were afraid of it. There was like two or three that were afraid of it. And then others where their insurance, they said no or something. But I am a believer in it, and it was no big deal to have done, and I believe it does protect um, sensitive area, which is right close to where these treatments are done. So
Right.
I am a big proponent. I just wanted to quick say that. That's
Yeah.
all.
From everything I read, it sounded like something that you would want to have for sure if it's available. And I was kind of surprised that Mayo said no, or at least this RO said no, don't need it. Um,
There are a lot of very reputable radiation oncologists who don't think it makes a difference, largely because the trials were jimmied a little bit. And when you hear these people talking, they will tell you exactly how they were jimmied. Um, if it were me at the time, I would have gotten it, except that one, my radiation oncologist doesn't like it, never has, and he wouldn't have given it to me. So it would have been difficult, but I would have still asked for it. But it's really debatable as to so if you can get it, take it. If you can't get it, don't knock yourself out. That would be what I would say. Steve Rue.
I just wanted to chime in about the spacer thing. I was supposed to have that, I think, inserted in my last brachia. And at the last minute, my radiation oncologist, which I think the world of, she said, no, we're not going to go that route. And then all the other radiation I had after that and events, I never had serious issues uh, at all with urinary problems or bowel movements or anything else along that line. Just maybe I got lucky. I don't know. But that's my story on that. I did not have the spacer and I didn't suffer for not having it. Thanks.
Thank you.
Thanks. Just one last quick question, because I know Ben has to move on. Did you get
Yep.
any genome? Have you gotten any genomic testing or genetic or genomic testing, Bill?
Yeah. Prior to this, this whole ordeal, I was offered this through my primary care clinic through a company called Helix Health in San Diego. So I'm negative. They test for 3 particular conditions: the BRCA1, BRCA2. I think they check 11 genes total across the board. All were negative for defects. So Lynch syndrome was the second one, and then the third was familial hypercholesterolemia. But I've also now, I just submitted a sample for the PROMISE
Okay, good.
trial. So I know they do more genes, I think, than that, more than 11. But anyway, so that's a positive. And I'm waiting on my Decipher test.
Yeah, I
So
mean, you don't need a Decipher test with the
Gleason 8,
biopsy not
yeah.
results that you have. It's not going to affect your treatment decision one way or the other, in my
Okay,
view.
okay. Wouldn't shorten ADT course at all.
Not if they suspect that NX is that node is positive. No.
Okay, thank you. Okay. Well,
You're
thanks for your help with everything here.
you're impressively knowledgeable, Bill. You've done a lot of homework.
Well, I started slowly, and like I say, when I went to Mayo, I wish I had known what I know now. Um, I could have been had a better conversation then. But but this group has been very helpful to me, and I've watched a couple of your YouTubes, and then the online user support groups as well have been very informative, and lots of great YouTube videos out there too. So thank you.
Thanks,
Are you
Bill.
signed up with us, Bill?
I am.
Okay, great.
I want to make, before we're done, I want to make one passing speech-like remark about proton therapy, which is not directly about proton therapy. A lot of medicine, a lot of therapies have really good rationales. They make so much sense. You wonder how it could miss. It just seems like the obvious thing to do. And proton therapy certainly falls under that category. No one can read the claims without thinking, of course, of course, of course. Um, what happens over and over in medicine is that things that ought to work don't, simply don't. When Rick talks about clinical trials not showing benefit, it's not because it doesn't seem that it doesn't seem beneficial. It just turns out that these claimed benefits, whether they exist or not, don't come out in the wash. It doesn't seem to make a difference. It doesn't lead to better outcomes. This is a this is an instance of a broad phenomenon. Every failed clinical trial pharmaceutical companies have staked millions of dollars on a clinical trial. They had every good reason to believe that the thing would work, but it didn't. So you should not feel if you don't get proton therapy that you've missed out on something great. Yeah, it sounds great, but in medicine we find over and over and over again that just because it sounds great, it doesn't necessarily work.
Right. And from what I've learned now about how advanced the photon therapy various versions are, that was something I was not aware of at all when I went to Mayo. So yeah,
Uh,
I'm going to check out Masonic, Rick. And
Antonarchus is very smart, and patients who see him really like him. So
great. That's my alma mater. So
better yet, thank you for coming. So Chief Rick, we have this is the moment of reckoning. We have one more new guy, and we still have our old guys, one, two, three, four of them.
I think we've got to go to our to our old guys, and we will defer Frank to next week, and I will be writing to Len Sierra tonight to tell him. So, and he'll be happy to have a Chiambra along with Sierra. He'll be very happy to have a countryman along with him. So you'll do just fine with Len.
Yes, I'm sorry, but you will be up first next time. We do appreciate your coming. So, in with the old Dr. Jeff, you had wanted to share something.
Yeah, just one point. I would just like to remind everybody to think about getting flu shots now. Um, we're immunosuppressed, some of us, and maybe cancer in itself without steroids causes some immunosuppression. So it would be terrible to get a bad flu um, when it's preventable. So that's my point. Flu shots.
Let
Thank you,
me add
Dr.
And
an
Jeff.
addendum. Can I add an
Huh,
addendum to that? Very brief. CVS is advertising getting both shots at the same time, and everybody seems to be doing it. I did it, and it was the biggest mistake I ever made. I was blown away. I mean, it really knocked me on my ass. I wouldn't recommend it whether you're immunosuppressed or I'm 85 years old. It doesn't work. It just really crippled me for a weekend. So I spread them out if you can. Spread them out by a week, which is what I've always done. Getting them both at the same time in different arms,
I
I
got
wouldn't
them
recommend.
both at the same time in the same arm. I got the senior flu shot and the new COVID, and I had no problems of any sort.
Well, you're a
yeah,
better man than I am.
yeah, I actually got three last time. I got the flu shot, the COVID shot, and shingles, and I did okay. But everybody's different, and I don't have any problem with Dr. Jack's recommendation. But just you know, be prepared. I was prepared. I did it on a Friday, and Dr. Jeff, you'll be pleased to know because of Len, I actually booked my flu shot and
Damn
my
it.
COVID shot for this Friday.
Well, notice I said flu shot.
I noticed that. I did notice that, but I was going to say, guys, please get your COVID shots. I mean, I'm a firm believer that the vaccines do make a difference. If you don't, we respect that too. But um, you don't want to go down with COVID.
Thank you, Dr. Jeff.
Yes, thank you, Dr. Jeff, for bringing that up. Really appreciate it, and Dr. Jack.
Steve L., thanks for waiting. You are next. Did we just miss him? I saw him a
No,
minute
he's
ago.
right there.
Oh, okay.
Steve, go ahead.
Steve?
Yes.
Yeah, okay, sorry. Yeah, I'm meeting with my GU Medical on con Monday, and a little confused of whether my treatment has failed and what I should be advocating for, and as far as testing or treatment goes. I'm de novo metastatic, reclassified as castration resistant earlier this year, um, and I'm on Lupron and abiraterone at this point.
And why do you think the treatment might not be working?
Well, my PSA started going up, and so I was reclassified as castration resistant at that point. Um, Although the PSA number is still fairly low, the most recent at 0.48. So,
And what's it been before that?
well, they started increasing in January, but then for 2 years before that, or two and a, it had been undetectable.
Is it rising
Um,
quick?
Go ahead, Ben, please.
Oh, I was just going to ask if it's rising quickly or kind of hovering, rising slowly.
I'm sorry, I didn't make that out.
Is your PSA, is it, so you say it is broken through, it's no longer undetectable. Is it
Correct.
rising? Has it been rising quickly?
Well, it rose in January to 0.11, and then in July it was 0.67, and then in August it was 0.48.
So it started to go down again.
Yes, after the only thing that happened in there was uh, the Provenge.
Hmm.
Were you able to continue the Provenge? I know you had back pain, right?
Yeah, I completed all three
Hmm.
Provenge,
Okay.
and the CT and the bone scans I've had have shown decreasing tumor size and no evidence of progression. So perhaps I'm fine just staying where I am. I just don't know.
What
My
is your medical? Oh, sorry. What is your medical team saying?
Very little. I don't get. I ask about treatments, and all I hear is, oh, that's not appropriate now.
So they want you to keep on taking the staying on your current treatment. They don't want.
Yeah,
They're not recommending a change at this point.
at this point, although this coming Monday there may be some difference. It'll be my first meeting in 3 months.
Have they told you when they would switch? How high
No,
they would want it to go, or what criteria they would use making a
no,
switch? You're entitled to ask.
and I have, but it's sort of we'll have to see when we get there. Is the
Oh,
type of response I get.
these guys.
So
Jeff
it does
Markey,
sound
I'm
like at
sorry.
least there's nothing urgent, doesn't it? I mean, right now it looks like you responded to Provenge, or may have anyway. PSA's turning around. Back pain's probably resolving.
Yes,
Pulmonary embolism resolving.
yes.
I don't know I'd be surprised if they wanted to change your treatment now. I don't know, Ben, what do you think?
I mean, I'm actually in a similar situation. My PSA has broken through, um, and I'm staying on hormone therapy, and I don't think it's a mistake, because the things that come next are worse. So if you can ride this out, I don't see that being a negative. Jeff,
Okay.
I'm sorry I interrupted you. What were you going to say, Jeff Markey?
I was on abiraterone for 2.5 years, and I went from point 1 to point 4 to point 5 to point 3 to point 5, point 6, point 7, point 4, point 2, point 2. So it just bounced all over the place, and it may be worth waiting another few months. If you can't, if your next step should be darolutamide if you can get it, because I've been undetectable for 10 months on that. But Zytiga, I was never steady. I was always bouncing around. And I guess, it might just be it's doing that to you as well.
Okay. Well, it sounds like I just need to have a little more confidence in my current situation. Uh, Thank you much.
Well,
That's it. Uh,
you asked what questions to ask. So,
Yes.
I would say a couple of things. The first thing is whatever questions you're going to ask, write them down on a piece of paper and hand that doctor that piece of paper. If
Okay.
you want to get proper answers and you don't want them to brush you off, then that's what you got to do. And there are a couple of things that come to my mind. First is, the first is a question for you, which was when was the last time you had a PSMA scan?
Uh, the, in January of 2022.
Okay. So the first question I would ask is, am I due for a PSMA scan? All right. Because I've been creeping up all year. I haven't had a PSMA scan for over 12 months, and I'm wondering what you're waiting for. So you can phrase that however you want, but that's the question that I would be asking them to kick off with, because there may be something there, and it may be that we just got to do a little spot radiation somewhere, and your PSA is going to run down, and rather than changing drugs and this, that, and the other, we don't know enough right now,
Yeah.
and I find it hard to understand, especially at a place like Fred Hutch, why the heck they haven't given you a bloody PSMA scan for going on 2 years.
Yeah.
Doesn't make
Over
sense.
2 years. Yeah. Yeah.
Yeah, I mean, doesn't make sense to me.
What
So I
is there a
think
minimum PSA number that you need to get results from a PSMA scan?
I would say that at point 0.5, which is where you are right now, it should be high enough to get a result.
Okay. Because it
Um,
wasn't, yeah, it wasn't point 0.5 until recently. So, yeah.
well, it doesn't matter whether it was point 0.7 in July. They could have done it in July, couldn't they?
Yes.
So, right. So, point 0.5, point 0.7, it's high enough. If you were telling me you were point 0, you were at a 0.05, I would say, I don't know. Point 0.1, I don't know. 0.15 maybe. Point 0.2, yes. Point 0.7 for sure. And point 0.5, I don't know what they're holding. I don't know what they're waiting for. Kingdom come. So, so that's what I would be asking them. Let's, how about a PSMA scan, folks? Now, depending on what the PSMA says, then we can talk about what's next. So I would pressure them to do the PSMA, and then after they've done the PSMA, have another meeting with them, and meanwhile stay the course with your abiraterone and see where you go from there. That would be that would be the most important question. What else am I going to ask them? I don't know. I don't have anything else to ask them until I know what the PSMA says. Anybody else got anything that he should add, that Steve should add to that list? Dr. Jeff?
So I would expand on your suggestion. Um, I would tell you, go on the portal and send a message on the portal and say, on my next visit, I would like to discuss the following issues. And rather than hand it to them the same day you're seeing the doctor, which doesn't give them much time to prepare anything, do it a week before. When I
Okay.
go to see my oncologist, if I have issues, I submit it a week before. And when I go in, she's printed it out. She said, all right, let's discuss A, B, C, D. So if you have access to a patient portal, I would use that as the
Yep.
way to communicate well in advance of the visit.
Good suggestion, but do yourself a favor. Take a copy of what you sent in with you in hard copy in writing, just in case they've missed it on the patient portal.
Yes. And I was also thinking that, the only biopsy I had was based, or the somatic testing is based on the biopsy from December of 2021. Should I just stick to the one request at this point, or do you think it's worth asking for more somatic testing at the same time?
Yeah, I mean, especially if they think that you might be becoming castrate resistant, I think that's a great suggestion. Yes, I mean, you could talk to them about when do they plan to check, since you haven't been somatically tested for a while and you've been on treatment for a while. I think that's a great suggestion. I missed that one, and yes, definitely.
Okay. Very good.
I
Thank you.
think that must have been what Gary Peters was going to suggest, the somatic testing, right, Gary? You're
Oh,
muted, Gary. You're muted.
Sorry, I was going to point out Steve's question in the chat. And the second part of that question, which I'm curious how Rick, you and the moderators would respond. What is the minimal PSA to have a meaningful liquid biopsy?
Well, I think I just answered that, Gary.
I thought you were talking about gene testing.
No, before that, because that's what Steve asked me. As I said, 0.1, if it was 0.05, I would say probably not. 0.1, maybe not. 0.15, well, there's that good paper by Peter Carroll and D'Amico that says, yeah, 0.15, we can make an argument. We should be looking. We don't want to be waiting more. 0.2, definitely.
But this was about the liquid biopsy. So is it the same?
Oh, you're talking, sorry, I beg your pardon. Forgive me. I'm sorry. You're talking about for a liquid biopsy. I don't know. I don't know on a liquid biopsy. I don't know. I'm sorry. I'm forgive me. I thought you were talking about PSMA. It's a lot of it with a liquid biopsy. From what I can gather, I'd be really interested to hear what the docs and Ben thinks. But a lot of it depends on your tumor history. So if you've got a fair number of tumors around your body, but your PSA is pretty low, there's a good chance that there's going to be CTCs, and at some point circulating tumor cells. And at some point, I think we'll see innovated tests to see what your level of circulating tumor cells are. They're doing this in other cancers right now. but we don't really see this test being used much in prostate cancer just yet. If we know that you've got significant number of circulating tumor cells, then a liquid biopsy to test is going to make sense. On the other hand, if you've never had a heavy tumor burden, and your PSA is low, I don't know if you're going to see anything. My gut is it's probably got to be at least around 1, if not more. But Ben, what would you say on that?
Yes, I'm feeling shamefaced. This is something that would be really good to know.
Nothing to
I,
contribute from what you've read?
I would have to do research. I do not know.
Dr. John?
No, I don't know either. But I do want to make one last comment before we go, Steve. I know there's hardly any time left, so I think this should only be mentioned and then move on. But we get a vibe of a not a trusting relationship, Steve, between you and Yazewski. And I would hate to have you go through the entire course of your prostate cancer treatment with that kind of feeling that you're probably getting put off, probably getting ignored, and not having trust. So if there's anything you could do to patch that up, it would serve you well in the future. We don't know him to be a bad doctor, so I think it's worth trying to fix it up.
Yeah, I will again ask, tell him that I'm the type of guy that appreciates more explanation, and ask him to provide that.
I'm sorry, did you say you have tried that and failed, or this is going to be a new tactic?
Oh, I've tried it. I'm going to try it again.
Huh? Yeah, you've got a terminal disease. There's no reason your doctor should make you feel worse. Um, Thanks, Steve. That you ended up getting a lot of good information out of that question. Um, so we have 2 guys remaining who asked for time. Should we just dive in, Rick?
Just go for it. Yeah. Go for it.
Okay, going for it. Jeremy, you're next.
Hello. First, I just started on the Orgovyx. I'm doing my first round of radiation tomorrow at City of Hope, Irvine. I wanted to bring up something just briefly for Bill, that City of Hope, Irvine is just a train ride away from San Diego. But that being said, with my treatment starting tomorrow, I wanted to relay a message, Rick, from our mutual friend Neil Brandon, and he just spoke with Keyshawn. Unfortunately, it appears he's got recurrence after salvage radiation, and his PSA is ticking up. And he did not opt for the recommended hormone treatment with the short course, as you know.
Right.
So
Well, just invite him to come back, and we'll unpack that
I
with
told him,
him.
and he said, relay what's going on. And with that being said, I come back to that question that, and concern that you've had from the very beginning, that since my PET scan and MRI imaging was negative and my PSA is still low, obviously it's around 0.2, up and down a little bit. And it's all negative, and City Hope is still saying, look, we just want to radiate the prostate bed and the bladder neck where there were positive margins. I mean, they got negative margins when they did my surgery, but I just wonder if they shouldn't.
I don't know what to say to you, Jeremy, because if it were me, I would go across the pelvic girdle. I've said that so many times on this
Yep.
broadcast, but these docs want to do it the way they do it.
They
And
seem
they
very,
can,
yeah. Keyshawn particularly was very, very adamant
I
about
know.
not doing the pelvic.
I'm on your side, but what we have to do is get a debate between Dr. Keyshan and Dr. Roach,
Yeah.
and see what they say to each other.
Well, look,
Um,
I'm seeing Dr. Percy Lee tomorrow after my first treatment, fortunately on a
yes,
Wednesday, and I'm going to bring it up. I'm going to say, hey,
yes,
look,
do.
the pelvic girdle.
Yes, do, and see what
Yeah,
he says, and come back
I
and
will.
tell us. Has
So that's all
anybody given you
I
any?
wanted to relay.
Yeah. Just a couple of quick pointers. I mean, hopefully, they're not going to be too focused on your bladder. You don't have a prostate, so I don't know that you need a full bladder. But have they given you any instructions as how they want you to come?
Yeah, no, with the bowels empty, and they do want the bladder full. They want this bottled water, 15 minutes before
Okay.
I get there, and
Okay.
go. And
Um,
again, to address, it is CT guided.
yes.
So,
Yeah.
and we'd been talking about the fiducials before, but this one is CT guided.
CT guided. So it
Yeah.
can be CT guided. I don't know if it wasn't Robert who was the first person up today, Jerry. I don't know if Jerry's still with us, but it can be CT guided as another. You just have to make sure it's guided, either with fiducials or with something or the other. It has to be
Well,
guided.
I think City of Hope knows what they're doing down
I
there.
think
So,
so. Yes.
yeah,
And I don't know what to say to you, but if it were me, I would. And it
I'll
came
bring it
back.
up.
I
I don't.
would want to get blasted across the pelvic girdle.
I don't know if
Um,
it'll be too late. I mean, this first treatment's in the morning, and then I see him in the afternoon. But I think they can always,
well, they can always adjust it. How
yeah,
many
exactly.
treatments are you getting?
38.
38. They got plenty of time.
Yeah.
Um, all right.
I'm gonna
And the
ask.
other thing I wanted to say to you is, and I know you're very good about this, but do make sure you exercise every day,
Oh yeah,
because the
I will.
fatigue will get to you if you don't.
I will. I am.
Okay.
Thank you.
Anyone else for Jeremy with him starting salvage radiation tomorrow? Any other words of advice for him from anybody? Guess not.
So the last man standing is David Muslin.
David Muslin. Come in, David Muslin. Well, he must have stepped away. Well, I've got a couple of people I just want to check in with quickly before we close out. That'll give David Muslin a chance to come back. Matt, you got in late. Is everything okay with you, man?
Yeah, I thought I'd just stop by and get some good vibes from the wise ones. Yeah, I'm one month out from my last SBRT treatment. Was a month ago.
Yeah.
I heard some of your earlier talks. I did not have space sore. I'm only 1 month out, so it's too soon to say kind of what's up. I was symptomatic urinary symptoms before I was even diagnosed with prostate cancer. I had really severe urine problems about a week and a half through the radiation treatment, but they've mostly resolved, which is great. And I'm 6 months ADT, and I'm doing all right. The radiation totally kicked my ass. I've never been so tired and weak and fatigued, and I had to stop exercising for a week, but I'm feeling better now, back on track.
And the other cancers are all good. The melanoma's
Yeah, the
good.
melanoma. I have a PET scan next week, Tuesday, I guess. Yeah, there's
Okay.
optimism it might be my first clean scan, but you don't know till you do it. So
Hope so.
yeah,
Really, I was
me too.
talking to a gent yesterday who has been through two immuno-oncology drugs. He went through IPI around 2014, and he went through Pembro in 2019, I think, both with stage 4 melanoma, and he's doing great. Seems like he has a lasting remission. So you did
That's
Pembro, didn't you?
Opdivo and
Opdivo. Yeah. Okay. Nivolumab.
Yervoy and Opdivo, but I had a
Yeah.
severe reaction with the Yervoy after 2, so scaled it back. But
Yeah. Yeah. So he did Yervoy and Keytruda. Same difference.
there you go. Yeah.
But he got and I'd be happy if you're interested. Let me know, and I'd be happy to connect you with him. His name is TJ Sharp, and he's a pretty significant patient voice in the melanoma community.
Yeah, you
So
can shoot me an email, no problem.
yeah, I'll connect you guys. I'm making a note to do that, and not other than other than the SBR from the SBRT, other than the fatigue, everything else seems to be okay at this point.
Yeah, got libido problems like everybody else and all that, but I'm
Yeah.
working through it. But yeah, I think everything's okay. I did send. I know we're at the end of the meeting. I'm so sorry, and I don't even need
It's
to
okay.
talk about it. You remember back in May we were talking about um, the paper that came out, but it wasn't the best study ever. Where folks I think it was people with more high volume metastatic disease though. There was a push or a call for uh, true triplet therapy, like even doubling up chemo on top of what I'm doing.
Hmm.
I kind of lost
Yeah.
track of what happened if that study was kind of ruled not valid, or if it was more for high volume metastatic.
I'm trying to remember which study it was. Ben, can you help me?
I think I know. Um, so the real question has been, do we really need the chemo part of it? And the practice
Yeah.
has always been for high volume, definitely yes. For low volume, studies are ongoing. It is finally
Okay.
being addressed. Does chemo confer any benefit, especially considering the harm it does? Does it confer any benefit in low volume cases? So they're still looking at that. But I think for high volume cases, there's no question that you should use all three.
Okay. Yeah. Well, I'm low volume, but no, it's good feedback. I imagine that's what my doctor would say. And then we might have even talked about it at one point where he's like, you want to leave some tools in the tool belt till you need them. So I think that's part of it too. So my PSA is undetectable. So ADT's working.
Okay, and don't forget we got an under 60 meeting this week.
I know I got work is actually becoming work again. I took 3 weeks
Oh.
off I took 3 weeks off for radiation. And then the first 2 weeks back were really hard. It was harder than I thought it would be, but anyway, yeah, I'll try to drop in
Well,
Thursday if we can. But
if you can drop by on Thursday for the under 60s group, we may have a couple of new gents. I don't think any of our new people this week who came in were under 60. Well, maybe Frank. I don't know. But we didn't get to him. But the other gents were all a little bit older. But anyway, David Muslin, I see that face. And Ben called on you.
Unknown caller.
Can you guys hear me now?
Yes.
Okay, great. I just wanted to bring everybody up to date real quickly. My PSA, I've taken a drug holiday about a year ago, and as of January, my PSA is slowly rising. And in January, it was 0.10. In June, it was 0.25. And in September, it was 0.75. I did a Pylarify scan in June, and it came up clean. I did a Pylarify scan last month in September, and he first told me it was clean, and then he followed up and said, I'm just bringing it up now. The pathology report said it could be a lymph node near my rectum. I forgot the name of that. And he said, don't worry about it. Let's just, in November, we'll do another pylarify test scan and we'll check your PSA and we'll see what's what. And, my hope is it's just going to be I'd love to find something because I'd love to get it zapped and not have to go back on ADT. But that's kind of my report right now.
Mm. But I think that especially in your case with your as we would say back in the homeland, your dicky tummy, um, your your delicate gut, um, can they radiate something close to the rectum? I mean, I think that's probably a significant question for you, David.
Yeah. So yeah, I was never really familiar with that lymph node, and they call it the pyrectal lymph node, left perirectal lymph node. So, but we'll scan again in November and we'll see. And we'll see. So my PSA is doubling every month, but we'll see. Right now it's still pretty low, but I expect it, if it's doubling like it is, I expect it to be in November, December to be probably over 2.0.
Okay.
That's my report, and I'm sticking to it.
Okay. Tony Fig, you got something you want to say to David?
Yeah, I was wondering if an MRI scan would be appropriate to take a look at that rather than waiting further for the PSMA scan again.
Could be. Shmuel didn't seem to be too concerned. He says it's rising slowly. The number's still low. He said, "I'll see you in November, and we'll take a look at it." Only because the PSA number is still low. But I don't know. I don't know what else. What do you think about that, Rick or Ben or anybody else? To do an MRI now?
With a doubling, I think I'd want to be a little more aggressive in searching it out.
But does it need to be searched out? It's already found.
That's all that he's found so far. And the number is still, relatively speaking, the number is still low. It's still only today it's at points, or last month it was at 0.75.
Look, I think that for me, it would depend on how we're going to treat it.
Yeah.
Right.
So if there was an opportunity for you to zap it without doing any damage to your rectum, then maybe you'd want to confirm it, because I'm not really sure when you say, well, they call back and they think now there may be something, but they're not sure. So now we got to look and see what the intensity was of that image, and does he need to confirm it? And if he says, well, yeah, we would really need to confirm it, then the question would be, you could say, well, can we confirm it with an MRI right now? And if we confirm it with that, can we do radiation right now? If the answer to either of those is no, then I don't see what difference it makes to wait, because he doesn't see the need to put you back onto therapy. And you don't want to be on therapy when you're sitting on the back of an elephant next week or in 2 weeks' time. So, I'd go with Shmulewitz. He's a good
Yeah,
doc.
I think so.
And
Basically, we're talking 6 weeks.
yeah.
Yeah, that's a short time. You know what? I
Yeah.
think Tony's idea would be good if there was a surgical approach. A CT or an MRI might help the surgeon design an operation, but otherwise, I don't
Can a
know
lymph
if it
node
would.
be taken out surgically?
Sure, but taking out don't we sort of know that taking out a metastatic lymph node doesn't really change the course of the disease very much. I don't know. I'm not really sure about that.
Well,
But
I think
yeah, I mean,
zapping.
this is really close to the outside of your body. I don't think it would be that hard to get it.
I mean, the thing is, and Tony, that's a good idea, but we don't know that it's metastatic. We don't know that it's related to the prostate cancer.
But I will tell you, looking at the report, it does say a new subtle avid left perirectal lymph node is compatible with metastases. That's what it says.
Okay.
How large is it, David?
How large is it, David? Let's see.
Is it millimeters or?
It has an SUV maximum equals of 2.6. That's what it says. I don't know what that means.
It means there's not a lot of uptake.
That's what they mean by subtle.
Right.
But they didn't measure it. They just told you the SUV uptake. They didn't give you the
Right.
measurement.
So listen, if it's growing and it's getting bigger or whatever, we should know. You should see that in the next Pylarify test next month.
Yeah, yeah. PET scan's kind of crap for exact measurements, isn't it?
Right. Okay. Yeah, he said, don't worry, enjoy life. He says, I'll see you in November. So he knows I'm enjoying life.
I agree.
Okay, you guys, thank you.
I agree.
Richard
Okay.
Fisk and Mike, when you tuned in like the last minutes, you know that this meeting started earlier, I assume.
Oh, absolutely.
Oh, okay.
I was at a rehearsal and was just able to get break free, and I got in as soon as I could.
It's great to see you. Thanks for joining.
Good to see you again, sir.
All right.
Thank you all for joining. It's been great.
Thank you. Good
We'll
night.
see you
Ben.
next week.
Yeah, thanks for your patience, Frank.
Good job.